Yeah. So, hi, my name's Tariq. I'm a cardiology and internal medicine registrar in Edinburgh, Scotland. And sorry, Dr. Dan Perry, it's not a very catchy title, so apologies about that. But it gives the story away, and it's not a rare condition, but I thought it had some quite useful and practical learning points. These are my co-authors and affiliations. If no one's visited Edinburgh before, it's a beautiful city if you ever get the chance, but don't drive a car. These are my disclosures for people who are going to ask questions at the end, so just be kind. So we'll go straight into the case. Mr. Blogg's the most common surname in English medicine, 67-year-old gentleman with a quite complex cardiac background, actually. Previous MI, Elvis systolic dysfunction, multiple admissions with VT storm, treatment with amiodarone on and off, and 2 previous VT ablations. Clearly the EP people didn't do a very good job. So I saw him in November last year when I was working in District General, which is sort of a smaller hospital. He came in with new onset palpitations, lightheaded that day, complaining of some non-specific fatigue, and had about 13 kilos weight loss over 6 months. He was in a number of cardiac medication because of his LV dysfunction, and his amiodarone was stopped 3 months ago after a presumed successful VT ablation. He was a little bit sweaty, had a bit of fine tremor, which was picked up by the endocrinologist who subsequently examined him, but no palpable goiter. His ECG showed new atrial fibrillation, and we interrogated his ICD, and it showed he had new AF on there again, but also 1 episode of sustained ventricular tachycardia, which needed anti-tachycardia pacing therapy, which is different to shock therapy. The blood tests were unremarkable except for his thyroid profile, which was very abnormal, and his thyroid receptor antibodies were negative. So based on this, we asked our friendly and clever endocrinologist for some advice, and they came up with a presumed diagnosis of type 2 amiodarone-induced thyrotoxicosis based on those criteria. I'll talk about clinical progress, but we didn't make much progress with him at all by day 9. He was on escalating doses of antithyroid drugs. For a change, steroids didn't do anything here, actually, which kind of bucks the trend from this morning. And his T4 actually remained above 100 by day 9. To sort of try and portray how sick he was, in a sense, I mean, his blood pressure was stable, but he was either in atrial fibrillation or always in persistent ventricular tachycardia. He wasn't compromised by this because his blood pressure, it was slow enough, so 120, 130, but it was quite alarming for us, and the number of cardiac arrest calls that went through that week in a small district general was unremarkable. So we ended up having to put him on some IV lidocaine to try and get on top of his VT. But at day 11, we had an MDT discussion with the endocrinologist, the cardiologist. We wanted to get him back on his amiodarone for his VT, and the endocrinologist suggested we should probably take his thyroid gland out. But because he was having so much VT and was unstable, we tried to stabilize him pre-surgery, and we asked our hematology colleagues for some help with some plasmapheresis. He had about 5 sessions over 7 days, and his T4 came down to 40. On day 27, he had an uncomplicated and successful procedure. He went back into sinus rhythm, no more VT, and we managed to stop most of his antithyroid drugs. And we saw him in clinic not long ago, and he remains arrhythmia-free on device interrogation and NYHA1 on a solid combination of antiarrhythmic therapy. This is a little graph that shows how his TSH and T4 kind of responded at various stages of presentation and treatment. I thought it was quite nice to see that the T4 came down nicely after plasma exchange. And a little bit about that, I'm not going to spend too much time on this, but iodine comes into the thyroid follicle, something happens, you get T3 and T4 that comes out, and peripherally you get conversion with deiodinase enzyme. And how does amiodarone affect the thyroid gland? Well, it's mostly 3 effects. It overwhelms it with iodine, so you get increased uptake. You get a direct toxic effect to the follicular cells, and you also get peripheral deiodinase inhibition. About 20% of patients will get some kind of thyroid dysfunction. Most of those will get hypothyroidism, which can be easily treated with some thyroxine if indicated. Again, I wouldn't make that decision. I'll pass that on to my friendly endocrinologist. But about 5% will get amiodarone-induced thyrotoxicosis. And there's 2 types which can often overlap to give a mixed form. In type 1, this tends to happen in iodine-depleted areas or patients with pre-existing thyroid conditions such as Graves', for example, and you essentially get autonomous production and secretion of thyroxine into the circulation. Whereas in type 2, you get damage to the follicular cells and you get a sudden release of T4 in the circulation. And diagnosis is obviously made based on symptom. Now, this could be thyrotoxicosis, or it could be as subtle as just a change in cardiac rhythm or cardiac decompensation. and obviously an abnormal thyroid profile and an uptake scan, which may be helpful, which we didn't do, and we don't tend to do color flow sonography in the UK, and I did ask about that because literature did suggest that. In terms of treatment, type 1 tends to respond quite well to antithyroid drugs, so your carbimazoles, your PTUs, and in terms of type 2, depending on how severe it is, you can either withhold your amiodarone after speaking to the cardiologist or simply give some steroids, which may or may not work. So this is just to break it down into simpler terms, and I think we kind of offered our patient all of these, and then we ended up having to go with plasmapheresis and thyroidectomy. This is a little summary slide showing an overlap of both type 1 and type 2 and the differences. And we actually had his pathology sample back recently, but I've not managed to discuss it with a pathologist. It is consistent with AIT, but I did wonder with the nodules whether it might have been a mixed type, but the endocrinologist does not think so. I think there's quite a few learning points in this case, but the main one for me from a cardiology and general internist point of view is, even if you've stopped amiodarone, you shouldn't get complacent, even a few months down the line. I think we should always keep the differential in the back of our minds, and sometimes because amiodarone blocks T4 to T3 conversion peripherally, manifestation can be quite subtle, and just a change in rhythm may be a clue. And obviously, speak to your endocrinologist, speak to a hematologist, and MDT discussion is always very helpful. Thank you.
Thank you very much. Another multidisciplinary case. In type 2, you mentioned it's destruction, which would be sudden release. Yet this sudden release may persist and persist and persist.
Pretty much. If you get ongoing destructive thyroiditis, you're going to still be producing thyroxine, but you're still going to get ongoing release into the bloodstream.
Okay, we have asked our colleague from Mexico, I believe, to comment here. René?
Hi, great presentation. I guess we've seen these cases, as you said, one of the most difficult things is to distinguish between type 1 and type 2. So in that sense, you said the antibodies were negative, but did you test for TSI, so stimulating antibodies? I guess you guys test for...
So it's full panel of thyroid receptor antibodies. I don't think we did any TPO testing, but it's a standard panel that we send, and it comes back with most of the stuff.
Okay, and ultrasound, doctor?
So we don't do, like I said, I did ask about that to our endocrinologist. I did ask whether, because there was some mention of radioiodine uptake scan at the very start. That didn't happen, I suspect, because of how unstable he was going in and out of ventricular tachycardia. But apparently we don't tend to do, where we work anyway, we don't have access to Doppler sonography.
Okay. And regarding amiodarone, so we're used to when there's an induced adverse thing regarding a medication, the usual thing is to stop the drug, right? But in this case, usually it might be worse to stop the drug. So it wasn't clear because amiodarone has these beta blockage properties and regarding conversion from T4 to T3. Mm-hmm. So it wasn't very clear to me why was amiodarone stopped.
Yeah, so in this case, initially the patient when he came was not actually on any amiodarone, and that was because he had a VT ablation 3 months ago, and we stopped it after that because the idea of doing the ablation was get rid of the VT and hence get rid of the amiodarone. In some cases, we'll have patients who come in already on amiodarone, and I think in that case you need to make a decision: how sick is the patient, or will they be compromised from a cardiac point of view? In this case, you could argue, well, could we go to dronedarone, but that's contraindicated if you've got LV impairment, which our gentleman does have. So I think continuing or stopping amiodarone will involve a discussion between the endocrinologist and the cardiologist, and again, it's going to be a balance of risk and benefits, and if there are alternatives.
And my final comment is that you used PTU. Why instead of metimazole?
So he was actually started on carbimazole initially. He was seen by an endocrinologist twice a day, every day that week. And I think because my suspicion was they didn't see a good reduction in T4, and they probably went for PTU to maybe mitigate some of the peripheral effects. But then again, looking at the blood profile, the free T3 or the total T3 was never really that high. So I can't quite explain why they went from carbimazole to PTU. I suggest my only thought is the added benefits of peripheral blockade.
Right.
Thank you very much. It strikes me that discussion of risks and benefits really turns out to educated guessing frequently. The next presentation.
Right, so now the next speaker is, thank you. The next speaker is Dr.